that. Recording over here.
Should I look at the camera?
If you're going to be reading mostly this, then read mostly that. Because if you switch back and forth, unless you memorize it, then you can go ahead and look back up there. But mainly, just go ahead and read this.
Okay.
All right, go ahead and state your name, and whenever you are ready afterwards, just go ahead.
Hello, my name is Pan. I'm a physician in NYU Langone Medical Center. Today, I have the opportunity to discuss with you about primary biliary cholangitis, diagnosis and treatment options. Primary biliary cholangitis, also called PBC, is a chronic cholestasis liver disease. It has autoimmune in nature and also have inflammation and destruction of small interlobular bile ducts. This disease usually affects predominantly in middle-aged female, and it has a rising incidence and prevalence in the United States. So how can we diagnose this PBC? PBC diagnosis mainly involve three major criteria. You can start with the biochemistry criteria. Usually is unexplained elevation of alkaline phosphatase more or equal than 1.5 upper limit of normal. And secondary, you have to look at the immune markers called anti-mitochondrial antibody, usually is positive. And lastly, you can do a histology assessment, which you may see non-suppurative destructive cholangitis. You must see your patients meeting those 2 out of 3 criteria in order to make a diagnosis of PBC. Besides a typical presentation, sometimes you may see patients have atypical variants of syndrome of PBC. First, patient may have AMA negative PBC. Approximately 50% of those patients had anti-nuclear antibody, so-called ANA. In this variant, PBC-specific ANA can be tested and show anti-GP210 or anti-SB100. They may have the same clinical presentation, but they have a poor survival. The second variant syndrome is overlap syndrome with autoimmune hepatitis. Because the autoimmune hepatitis nature, they may have a higher level of transaminase. So when you test the alkaline phosphatase to transaminase ratio, they could be less than 1.5. And also their IgG is elevated. And SMA, so-called smooth muscle antibody, is also present at the level of above 1 to 80. So lastly, you can see a variant syndrome of premature ductopenia variant. This is a very poor diagnosis, Besides a typical presentation of PBC, you can also see variant syndromes. This includes 3 types of variants. First is AMA negative PBC. Approximately 50% of those patients with this variant will have ANA positive, which is anti-nuclear antibody positive. In this type of variant, patient also had a clinical presentation similar to those typical PBC, but they may have reduced survival. However, PBC-specific ANA could be tested as anti-GP210 or anti-SB100. The second variant of this syndrome would be overlap syndrome with autoimmune hepatitis. In this variant, hepatitis is dominant, so the transaminase would be higher than usual. When you measure the alkaline phosphatase to transaminase ratio, usually is less than 1.5, and their IgG could be elevated, and the smooth muscle antibody are present with a titer more than 1 to 80. Lastly, you may have a premature ductopenic variant. In this subtype syndrome, you can see a very rapid onset of ductopenia, severe icteric cholestasis, and fast progression towards cirrhosis. This subtype of patients take up to 5 to 10%. How can we diagnose PBC? In clinical setting, approximately 6 to 70% of those patients actually would have no symptoms, but eventually presented with PBC. If they have symptoms, majority of them actually have pruritus, fatigue, and Sjögren's syndrome. Another name for Sjögren's syndrome is Zika syndrome. Approximately 5 to 10% of those patients presented with cirrhosis at initial clinical assessment. They may have portal hypertension even though they did not have cirrhosis yet. So how can we manage those patients? Initially, we need to do a baseline assessment, which include chemistry assessment and immune markers assessment, staging, and also we need to perform a DEXA scan to assess patients' bone minimal density. And after we do the baseline assessment, then we can start patients on the first line treatment, which is ursodeoxycholic acid. Later on, we'll get into a little bit more detail about the dosage and duration, how we can use it. And after you initiate the therapy, you should do a close follow-up for those patients. In long-term follow-up, usually after 1 year, you can assess the patient's responding rate. Some of the assessment criteria we'll discuss a little bit more in detail later on. Also, patients need to be monitored for disease progression, such as cirrhosis, portal hypertension, whether patient have thrombocytopenia, and also they need to be on EGD surveillance. The biochemistry assessment, you can also base on those values to assess the risk after 1 year treatment for disease progression, and whether they need further second-line treatment or further therapy intervention. And lastly, in long-term monitoring, we can also assess the histology improvement, which improve with the therapy, could be assessed by FibroScan or transient elastography. Now let's talk a little bit more about, in detail, for the first line treatment, which is ursodeoxycholic acid. This is the medication can be used once a day based on patient's body weight, 30 to 15 milligram per kilogram, can improve the liver's test approximately in 90% of those patients. Usually this improvement can be seen between 9 months to 1 year. After 1 year treatment, the number of patients with biochemical response can be assessed based on different criteria. If you use a Paris criteria, you would expect about 66% of those patients will respond to the first line therapy. Or you can use a Barcelona criteria, which is more restricted, and you can expect about 62% of those patients who respond to therapy. So in general, you have a responding rate about 60%. However, up to 40% of those patients treated with this first-line agent still have suboptimal response. So in summary, the therapeutic effect of ursodiol include biochemistry response, which can improve total bilirubin, alkaline phosphatase, GGT, and transaminase. And also you can expect patients get improvement on cholesterol and IgM. And that will translate to improved survival free of liver transplantation. And this patient, usually when you assess their histology, they can have improvement of histology or delay histological progression, or delay on development of the complications such as esophageal varices. Now, how can we assess the patient's response after 1 year? There are several assessment system or criteria exist, such as Barcelona criteria, Paris, Toronto, Mayo, etc., etc. And also some clinicians may use APRI as assessment criteria, but what I would like to discuss a little bit more in detail is the Globe PBC score after 1 year treatment. In this score, I mainly include the clinical parameters, which is biochemical parameters, total bilirubin at 1 year, alkaline phosphatase at 1 year, albumin and platelet at 1 year. And also, we need to include patient's age at initiating the therapy. So the Globe score actually can predict 3, 5, and 10 year survival compared to the age-matched population. Now, what if you have a patient suboptimal or non-respond to urso after 1 year treatment? Then we can consider a second-line treatment. And I'm going to discuss a little bit more in detail about a new treatment for PBC, which is obeticholic acid, OCA. This medication actually is a nuclear receptor agonist, which can serve as a ligand to bind on the nuclear receptor and up or down regulating the bile acid homeostasis, which you can expect when the medication effectively binding on the receptor. That could decrease the bile acid synthesis, decrease the bile acid uptake, decrease the bile acid absorption, and meanwhile increase the bile acid secretion. As the result of this effect, patients have much less bile juice production and leading to cholerasis. Meanwhile, this medication also can improve the inflammation pathway, which could downregulate NF-κB, tumor necrosis factor alpha, and also decrease IgM and CRP. So let's look into the clinical data. And recently, a large clinical trial on OCA, so-called POISE study, has been published in New England Journal of Medicine. In this clinical trial, patients were randomized to 3 arms. Either they receive placebo or OCA 10 milligram or 5 milligram with the option of titrate up to 10 milligram. These 3 arms will be observed for 1 year, and at the end of the year, patient will be reassessed and then go on maintenance therapy from 5 milligram to 10 milligram of OCA after 60 months of follow-up, which is the stage of open label phase. So the titrate up criteria for 5 milligram group would be the following. If the patient could not meet the primary endpoint, which is alkaline phosphatase less than 1.7 times upper limit of normal, or bilirubin could not be normalized, then they will meet the criteria to be titrated up. And also, this patient must show no evidence of tolerability issues. In other words, they did not develop pruritus. So in this slide, actually show the primary endpoint of treatment arm versus placebo arm. As you can see, the orange color represent the treatment group, 5 to 10 milligram, and the blue color represent the 10 milligram higher dose group. Then the transparent color represent the placebo. And during the first phase, double-blind phase, up to 12 months, the higher dose group, 10 milligram, and the lower dose group, 5 to 10 milligram, have shown very effective effect in terms of improved biochemistry when compared to the placebo. And also, latest phase, on the open label phase, you'll see a similar effect. It doesn't matter 5 milligram or 10 milligram group, also seen significant improvement in biochemistry. So the following slides are the breakdowns on biochemistry markers. Here is the alkaline phosphatase level in double-blind phase and open label phase. As you can see that there is a significant improvement in the first stage and the second stage of treatment. And not only that, the total bilirubin level, showing this as line in both phase, and also have a significant improvement compared to the untreated group. This is the figure showing liver biochemistry over time in terms of the mean level of bilirubin, so in figure A, and GGT in figure B, ALT, AST in figure C and D, which shown that in significant improvements starting from 3 to 6 months, and you can see remarkable improvements at the end of 12 months. Not only the chemistry improvement, but also the immunoinflammation markers can be improved with the treatment in these patients. As you can see here, patients with the placebo arm is showed in the white color, and blue, orange showed it in the treatment arm. And in figure A, it shows the IgM level through the first 12 months. And then the IgA level, IgG level also improved at the end of 6 months. Then in figure B, CRP improvement, tumor necrosis factors, and IL-12, those are the inflammatory factors, improve throughout 12 months, 6 to 12 months treatment. And lastly, the lipid value over time of 2 phases also show significant improvement in this study. As you can see in figure A and B, that will reflect the cholesterol levels, and figure C and figure D will show the cholesterol levels and triglyceride levels. In terms of the worst event in post study, here lists up the most common 5 common adverse events reported during the study patients. Pruritus has been shown quite common in those patients with high dose and phase 2 study, which is using 50 milligram. However, 5 to 10 milligram, it did not show significant pruritus when compared to the placebo. So in this study, as you can see, 28% of those patients with placebo actually would have the pruritus versus 56%. And in 10 milligram group, it's 68%. So there is no statistical significance. The other uncommon adverse event with less than 15% include nasopharyngitis, headache, fatigue, and nausea. SAE were very rare among those study patients, approximately 4 to 16%. There was no differences between the study group and the placebo group. in pruritus,
Hold on 1 second.
yes.
Go ahead. Yeah, in provider.
In assessment of pruritus, when we use a VAS score, as you can see in this study data set, the pruritus probably would be more common in 10 milligram group. However, after the initial treatment, 3 months down the road, the pruritus score actually have been decreased and quite similar at the end of 6 months and almost superimpose the two graphs superimpose at 12 months. So in summary, when we look at this POISE study, the effect of OCA was consistent independent of age at diagnosis during the PBC and baseline alkaline phosphatase. Titration from 5 milligram to 10 milligram based on the clinical response can actually improve the tolerance, minimize the dropout due to the pruritus, and show comparable efficacy to 10 milligram after 1 year. Therefore, starting patients on OCA 5 milligram with titrating up to 10 milligram based on clinical response appeared to be an appropriate dose strategy. So therefore, OCA can be given to individuals with PBC with inadequate response or unable to tolerate UCA ursodeoxycholic acid treatment. And the treatment with OCA can significantly improve liver biochemistry and also immune markers. So lately, FDA have approved such indication for OCA, which include serve as a second-line treatment in adults with PBC who could not be in response to and recently FDA have approved the indication for obeticholic acid treatment for PBC patients. Lists us 2 indications. The first indication is to use for patients who did not respond to ursodeoxycholic acid with treatment after 1 year, or patient who cannot tolerate ursodeoxycholic acid treatment. Obeticholic acid treatment can be used as monotherapy in those patients couldn't tolerate the treatment. With that, we will discuss lastly about the monitoring or long-term management of patients based on AASLD guideline. So AASLD guideline recommend that patients with PBC should be monitored every 3 to 6 months with liver tests, and also thyroid status should be assessed with TSH. Bone mineral density could be measured every 2 to 4 years. And we need to monitor for fat-soluble vitamin deficiency because when cholestasis patients may have vitamin deficiency. We also need to perform upper endoscopy every 1 to 3 years because we know that patients, they could have portal hypertension and esophageal varices even without cirrhosis. But if they have cirrhosis, close surveillance is required. You can also, based on a Mayo Research score, more than 4.1 or platelet count less than 140,000 to initiate the assessment of varices by EGD. And finally, patient needs to get hepatocellular carcinoma screening, which will be screening with sonogram every 6 months, and alpha-fetoprotein is optional. I thank you for your attention. Okay,
All right.
so I paused a couple of times.
I heard.
because